Here's something your annual physical was never designed to tell you. After the age of 65, certain routine medical tests, the ones your doctor orders almost automatically, the ones insurance covers without question, the ones you've probably done for decades, can set off a chain of medical events that does more damage than the condition they were looking for. I've spent 20 years in clinical medicine, and the cases that stay with me, the ones that genuinely keep me up at night, aren't the ones where we missed something. They're the ones where we found something we weren't equipped to handle wisely, where a well-intentioned screening test became the first domino in a very long fall. Look, if you're between 55 and 75 and you're relatively healthy right now, what I'm about to share could genuinely change what happens to you at your next annual checkup. Not because medicine is the enemy, it isn't, but because the risk-to-benefit equation changes dramatically with age, and almost nobody is running that math with you in the room. In this video, I'm walking you through 5 specific medical checkups I would personally reconsider after 65. For each one, I'll tell you what the research actually shows, what the real risks are, what questions to ask your doctor, and what smarter alternatives exist. By the end, you'll have a 5-question framework you can bring to every single appointment, one that will completely change the dynamic between you and your physician. Stay through all 5. Number 3 is the one that makes most people genuinely pause. And number 1, I saved that for last because it's the one I've personally had the hardest conversations about with my own patients. If your doctor doesn't have time to explain this, I do. Subscribe and hit the bell. New video every week. Let's get into it. Quick question before we dive in. How old are you right now? Just drop the number in the comments below. I read every single one. Go ahead, I'll wait. Let me tell you about a patient of mine, retired postal worker, 71 years old, sharp as a tack, the kind of guy who does the crossword every morning without looking anything up. His wife dragged him in for a physical because he'd skipped 2 years during the pandemic. He felt fine, genuinely fine. Sleeping well, walking 2 miles a day, blood pressure manageable on 1 medication. His new primary care physician, and well-meaning, thorough, ordered a full panel of screening tests. Standard stuff. Part of the workup flagged a mildly elevated PSA. That led to a biopsy. The biopsy found a low-grade, slow-growing prostate abnormality. His urologist recommended treatment. He trusted her. Why wouldn't he? 18 months later, this man who had been walking 2 miles a day was dealing with fatigue that kept him on the couch by 2 p.m., urinary complications that affected his dignity, and a depression he'd never experienced before in his life. His wife told me quietly that the person who came home from treatment wasn't quite the same person who walked in for that physical. Here's what the research would have told them up front. The type of finding he had was, statistically, one that the majority of men his age already carry without knowing it, and carry without consequence. It grows slowly. It causes no symptoms. In most cases, it never becomes the thing that takes your life. I'm not telling you this story to scare you away from doctors. I'm telling it because that man deserved a different conversation before any of this started, and so do you. Before we get into the 5 checkups, you need one concept, because without it, none of what I'm about to say lands properly. I call it the age-adjusted risk shift. When you're 45 or 50, screening medicine has an elegant logic. You catch something early. You treat it. You potentially add 20 or 30 years of healthy life. The math is clean. The investment pays off. But 3 things change dramatically after 65, and especially after 70. First, silent conditions become more common, not more dangerous. Aging bodies accumulate biological quirks. A small nodule here, a shadow on a scan there, a slightly elevated marker. Most of these will never cause a single symptom in a person's remaining lifetime. But once they show up in a report, the clinical machine doesn't have a leave it and watch setting as its first instinct. It has a treatment pathway, and treatment pathways have their own risks. Second, your body's tolerance for intervention changes. A procedure that a 52-year-old bounces back from in 2 weeks can mean a fundamentally different recovery at 74. Anesthesia hits differently. Healing takes longer. Complication rates climb. The surgery isn't the same surgery just because it has the same name on the chart. Third, cascade effects. One test finds a small abnormality. That abnormality requires follow-up imaging. The imaging recommends a biopsy. The biopsy leads to a specialist consult. The specialist recommends intervention. The intervention causes a complication. And suddenly a person who walked in feeling well is managing a medical situation that has genuinely altered their life, all starting from a test that the evidence didn't support ordering in the first place. Keep that in your mind as we go through each one. Checkup number 5, routine cardiac stress testing without symptoms. This one surprises people because on the surface it sounds completely reasonable. You're 68. Your doctor says, let's just do a stress test. Make sure the heart's doing okay. You appreciate the thoroughness. You agree. Here's the thing most patients don't know going in. Cardiac stress tests in asymptomatic adults, meaning people with no chest pain, no shortness of breath, no exercise intolerance, carry false positive rates that can reach 40% or higher in certain older adult populations. Nearly half the time, the test waves a red flag when your heart is actually functioning fine. But here's the problem medicine hasn't fully solved. You can't just shrug at a red flag. That abnormal reading launches you into the next investigation, typically a cardiac catheterization. That means threading a thin tube through your blood vessels, through your wrist or groin, directly into your coronary arteries. It's not a blood draw. It's a serious vascular procedure with real risks: bleeding, arterial damage, arrhythmia, and in rare cases, it can actually trigger the cardiac event you were trying to prevent. And here's the part that genuinely changed how I counsel patients. If the catheterization finds a stable partial blockage, which is extraordinarily common in adults over 65, most of whom have no idea it's there, the instinct is to place a stent. Sounds logical. Fix the blockage, reduce the risk. The ischemia trial, one of the most significant cardiovascular studies of the last decade, involving over 5,000 patients across 37 countries, found that in patients with stable coronary artery disease, stenting did not reduce heart attacks or extend life compared to medication and lifestyle management alone, not meaningfully. But the stent and the lifetime of dual antiplatelet therapy that follows introduced its own risks: bleeding complications, ongoing monitoring, a new label, and a new set of worries. So the chain looks like this: feeling fine, routine test, false alarm, catheterization, stent, blood thinners, complications. And the data says the endpoint is statistically no better than if you'd simply optimized your blood pressure, cholesterol, and physical activity. Well, to be more precise, there are absolutely situations where stress testing and catheterization are the right call. Active chest pain, new shortness of breath during exercise, palpitations. Those symptoms change the equation entirely. Go get tested. Don't hesitate. But routine cardiac stress testing in asymptomatic older adults? The evidence doesn't support it the way most patients assume it does. Talk to your doctor about optimizing actual cardiovascular risk factors: blood pressure below 130/80, LDL cholesterol, blood sugar, physical activity, sleep quality. A 2022 analysis in the Journal of the American College of Cardiology found that consistent moderate intensity walking, 30 minutes, 5 days a week, reduced major cardiovascular events by 35% in adults over 65. No procedure, no recovery time, no false positives. Coming up, checkup number 4. And this one is going to challenge something you've probably been told is protecting you. Don't go anywhere. Checkup number 4, routine bone density scanning leading to automatic medication. Let me be clear about what I'm saying here, because I don't want anyone to hear this wrong. Bone loss is real. Falls in older adults are genuinely serious. Hip fractures in people over 70 carry a 1-year mortality rate that most people would be shocked to hear, somewhere between 15 and 36% depending on the study. This is not a small concern. What I'm questioning is the automatic pipeline that often follows a bone density scan, specifically in patients who have never had a fracture, who are active, and who may not actually need pharmacological intervention. Here's how it typically unfolds. You get a DEXA scan, it shows low bone density, and you walk out with a prescription for a bisphosphonate medication like alendronate or risdronate. Your doctor means well. The guideline often supports the decision, and you assume you're now protected. But here's what frequently goes unmentioned in that appointment. Long-term bisphosphonate use has been associated with a rare but mechanically counterintuitive complication: atypical femoral fractures. Stress fractures in the shaft of the thigh bone, the very bone the medication was supposed to be protecting. A 2020 study in JAMA Internal Medicine found that long-term bisphosphonate use, beyond 5 years, was associated with a significantly elevated risk of these fractures compared to shorter-term users. These aren't minor cracks. They can require surgery and extended rehabilitation. Additionally, osteonecrosis of the jaw, bone deterioration in the jaw triggered by dental procedures or even spontaneously, is a documented complication, particularly with longer duration of use. It's difficult to treat and significantly affects quality of life. Now here's the part that honestly surprised me when I first dug into this research. The single most effective intervention for reducing fractures in older adults isn't a medication, it's fall prevention. A 2021 Cochrane review, the gold standard of systematic reviews, found that structured balance training reduced fall-related injuries in adults over 65 by up to 42%. Tai Chi specifically has been shown in multiple randomized controlled trials to reduce fall risk by nearly 50% over 12-week periods. Grab bars in the bathroom, non-slip mats, a review of any medications causing dizziness. Vision checks, because poor vision is one of the most underappreciated fall risk factors in older adults. Adequate protein intake, because muscle loss is what turns a stumble into a fall. Vitamin D levels checked, not assumed. Before we talk about medication, ask your doctor, what is my actual fracture probability based on the FRAX score, and what would a structured fall prevention program do for that number compared to the medication? That question alone will change the conversation. Checkup number 3, routine colonoscopy after age 75 in low-risk patients. I want you to pause on this one, because this is the checkup I see ordered most reflexively in patients over 75, and the one where the risk-benefit math has shifted most clearly in the research. The United States Preventive Services Task Force, the independent body that sets evidence-based screening guidelines in this country, explicitly recommends against routine colonoscopy screening for average-risk adults over age 75. Not as a suggestion, as a formal recommendation against based on a systematic review of the evidence. Here's the clinical reality behind that recommendation. Colonoscopy is not a risk-free procedure. Bowel perforation, a tear in the colon wall, occurs in approximately 1 in 500 procedures. In a 55-year-old, that's a manageable surgical complication. In a 78-year-old with any underlying vascular or cardiac issues, emergency abdominal surgery carries a very different risk profile. Anesthesia complications in older adults are not trivial. The prep, the bowel cleansing process the night before, can cause severe electrolyte shifts that strain kidneys and put hearts at risk. A 2016 study in Annals of Internal Medicine modeled the benefit of colonoscopy at different ages and found that for average-risk individuals who had completed prior screening, the procedure provided diminishing returns after 75, and at some ages, the harms began to outweigh the benefits. Here's my honest take. If you're 78 years old, you've had 2 clean colonoscopies in your 50s and 60s, you have no symptoms, no family history of colorectal cancer, and no new changes in bowel habits, the conversation about whether to do another one deserves to happen. It's not automatic. It shouldn't feel automatic. Stool-based testing, the FIT test annually, or the multi-target stool DNA test every 1 to 3 years, can detect meaningful warning signs without procedural risk. If you have symptoms, blood in the stool, persistent changes in bowel habits, unexplained weight loss, anemia, that changes everything. Go. Get evaluated. Don't let anything I've said today talk you out of that. Symptoms are different from routine screening. Before we get to checkups 2 and 1, which is honestly where this gets most interesting, I want to check in with you. Of everything we've covered so far, which one surprised you most? Drop a number in the comments right now, 5, 4, or 3. It takes 2 seconds and it tells me exactly which topics to go deeper on in future videos. Checkup number 2, aggressive cancer screening in average-risk patients over 75. This is the topic I approach most carefully because the word cancer carries a weight that can shut down nuanced thinking. And nuanced thinking is exactly what this requires. I am not telling you to stop screening for cancer. Cancer is real. Screening has saved millions of lives. If you have a family history, genetic markers, prior abnormal results, or any symptoms, screen. That equation is different, and I'm not addressing it here. What I'm addressing is this. Routine, aggressive cancer screening in average risk, asymptomatic adults over 75 has a documented overdiagnosis problem that the medical literature has been grappling with for over a decade. Overdiagnosis means this. Imaging technology today is extraordinarily sensitive. It can detect cellular changes that, in a younger patient, might evolve into a dangerous cancer over 15 to 20 years. But in a 76-year-old, those same changes, left entirely alone, would never cause a symptom, never spread meaningfully, and never shorten their life. The person would live alongside that finding, not die from it. The problem is that once a radiologist uses the word malignancy in a report, the clinical process doesn't pause to ask whether intervention is actually warranted for this person at this age. It moves forward. Biopsy, specialist, treatment decision. And treatment, chemotherapy, radiation, surgery, carries consequences for a 76-year-old body that are categorically different from the consequences for a 56-year-old body. A landmark study published in the New England Journal of Medicine found that a significant proportion of breast cancers detected through mammography in women over 70 were clinically low risk, meaning treatment provided no measurable survival benefit while exposing those women to the full side effects of cancer therapy. For prostate cancer specifically, autopsy studies have consistently shown that a large proportion of men over 70, estimates range from 50 to 80% depending on the study, have pathological evidence of prostate cancer at death that never manifested clinically, never caused symptoms, and was not the cause of death. They died with it, not from it. The American Geriatric Society now explicitly recommends individualized rather than automatic cancer screening decisions for adults over 75, taking into account life expectancy, functional status, and patient values. Here's what a good conversation looks like. If this screening finds something, what are the realistic treatment options for someone my age? What are the side effects of those treatments? And what is the likelihood this finding would actually threaten my life in the next 10 years? Those questions don't make you a difficult patient. They make you an informed one. And now, checkup number 1. I saved this for last because when this one goes wrong, it goes wrong in a way that is almost impossible to explain to a family afterward. Checkup number 1, asymptomatic carotid artery ultrasound screening. Here's the premise. A carotid ultrasound checks the large arteries in your neck that supply blood to your brain. If a significant blockage is found, surgeons can clean it out, a procedure called a carotid endarterectomy. Reduce the blockage, reduce the stroke risk. Sounds logical. Here's the data behind that logic in asymptomatic patients. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms. No prior TIAs, no sudden vision changes, no episodes of facial weakness or arm numbness, no neurological symptoms whatsoever. Their reasoning, the surgical procedure used to treat a significant carotid blockage carries a 2 to 3% risk of causing a stroke during or immediately after the procedure itself. In older adults with additional health conditions, that risk is higher. Some real-world surgical outcomes reach 5 to 6%. Now think about what that means practically. You walk in with no symptoms. The ultrasound finds a 70% blockage, which sounds alarming. Your vascular surgeon recommends fixing it. But the evidence shows that for many asymptomatic patients, the risk of the surgical fix is comparable to, or greater than, the annual stroke risk posed by the blockage itself, especially if it's been stable for years. Many people over 65 have some degree of carotid narrowing. It's biologically common. Most of it is stable. Most of it never causes a TIA or a stroke. But once it's found on an image, it creates a medical urgency that may not reflect the actual biological urgency. I've sat with patients and families after complications from procedures that followed asymptomatic carotid findings. Those conversations are among the hardest I've had in 20 years of medicine. Control your modifiable stroke risk factors. Blood pressure is the single largest driver of stroke risk in older adults, far more impactful than a stable carotid finding. Atrial fibrillation management if you have it. Blood sugar, smoking cessation, physical activity. These interventions reduce stroke risk in ways that are measurable, documented, and carry essentially zero procedural risk. If you do have neurological symptoms, sudden vision changes in one eye, brief arm weakness, facial drooping, slurred speech that resolved, those are TIA warning signs. Get evaluated immediately. That's a completely different situation, and nothing I've said today applies to it. Okay, here's the part you actually came for. You now know which checkups carry risks that outweigh their benefits in certain age groups. But knowing is only half of it. Here's how you walk into your next appointment prepared. Your 5-question protocol. Write these down, put them in your phone, bring them to every appointment. Question 1. What is the false positive rate of this test for someone my age? This one question reveals whether the test is more likely to find a real problem or send you down a follow-up rabbit hole. Most doctors know this number, many just don't volunteer it. Question 2. If this test finds something, what are the realistic treatment options for someone at my age and health status? Force the conversation toward outcomes, not just findings. A finding that leads to a treatment you can't tolerate is not a useful finding. Question 3. What is the procedural risk of the treatment we'd most likely pursue? Every procedure has a complication rate. You deserve to know it before the scan, not after. Question 4. What happens if we monitor this instead of treating it? Watchful waiting with regular check-ins is a clinically legitimate strategy for many conditions found in older adults. Ask if it's on the table. Question 5. What's the most effective non-invasive intervention for this condition? Because for cardiovascular health, bone health, and stroke prevention, lifestyle and medication frequently outperform procedural intervention with dramatically lower risk. Tonight, write these 5 questions down and put them somewhere you'll actually see them before your next appointment. I know this can feel like a lot to process. That's completely normal. The medical system hasn't been designed to make these conversations easy. Insurance incentivizes testing. Time pressure in appointments discourages nuance. That's not a conspiracy, it's a structural problem. And the way you protect yourself from it is information, which is exactly why I make these videos. Remember what I told you at the very beginning, that the cases that stay with me aren't the ones where medicine missed something, but the ones where finding something set off a chain of events the patient was never prepared for. Now you understand the mechanism behind that. Now you understand why the math changes after 65. And now you have the language to walk into your next appointment and actually advocate for yourself. Here's your quick recap. Routine cardiac stress testing without symptoms carries false positive rates exceeding 40%, and the downstream procedures carry the very risks the initial test was designed to prevent. Optimize your risk factors instead. Automatic medication after a bone density scan may introduce complications of its own over time, and fall prevention programs reduce fracture risk by up to 42% with zero side effects. Ask about that option first. Colonoscopy after 75 in average-risk asymptomatic patients is explicitly recommended against by the United States Preventive Services Task Force. Non-invasive stool-based testing is a viable, lower-risk alternative. Aggressive cancer screening over 75 in average-risk individuals has a documented overdiagnosis problem, and overdiagnosis leads to overtreatment with consequences that outweigh the benefit for many patients. Asymptomatic carotid artery ultrasound carries a procedural stroke risk that the evidence has determined outweighs the screening benefit in patients without neurological symptoms. You now have the information, the framework, and the specific language to walk into your next appointment and advocate for yourself. Most people don't have that. You do now. If this video shifted something for you, if it gave you language you didn't have before, or answered a question you've been sitting with, drop one word in the comments right now. The word is ready. That's it. One word. It tells me this video did what it was supposed to do. This channel exists for one reason: to give you research-backed, clinically honest health information, the kind you deserve to have and rarely get in a 15-minute appointment. If that's what you've been looking for, subscribe, hit the bell. I am not going anywhere, and neither is your right to understand your own health. My next video covers something I've been getting asked about constantly: the 5 medications most commonly prescribed to adults over 65 that new research suggests may be doing more harm than good. One of them is something I personally had to reconsider recommending after reviewing a 2024 study. And I haven't talked about this publicly yet. I'll see you there. This video is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with your physician or qualified healthcare provider before making any changes to your health regimen.